everyone, my name is Pei Fang and my group today is going to be presenting on ectopic pregnancy. So now let's take a look at our role play on our case scenario.
Okay.
Morning doctor.
Good morning, Sarah. How can I help you today?
I actually missed my menses for about 10 weeks already and I did a pregnancy test kit at home and it seems to be positive.
Okay, so do you have any concerns?
Actually, yeah, I do have some concern because I actually had 4 spontaneous abortions previously and I experienced like bleeding, vaginal bleeding this morning and I actually have some abdominal pain as well.
Okay, so I'll just order a urine pregnancy test for you so that we can confirm your pregnancy and then we can see what else we can do from there. Is that alright?
Yeah, okay, thank you. Okay, so to summarize our case scenario, our patient name is Sarah. She's 36 years old. Her last menses period was actually 10 weeks ago and she actually did a pregnancy test kit at home and it shows that positive. So she actually said that she actually had 4 times of spontaneous abortion. So why she went to the gynae clinic? Because she actually has abdominal pain and also slight vaginal bleeding this morning. So at the clinic, she actually had the doctor actually redo a pregnancy test kit and it shows that it's positive. So the estimated gestational weeks is about 9 weeks and the doctor actually examined her on the abdominal. So there was actually a bulging at the lower abdominal region. So the doctor actually did a pelvic ultrasound for her and found that there was an absence of zygote in the uterus. Hence the doctor actually suspected that she's having an ectopic pregnancy. They then proceed to do a transvaginal ultrasonography and it is confirmed that there's an ectopic pregnancy at the fallopian tube. Okay, so next the doctor actually refer her to the A&E department because she's confirmed for ectopic pregnancy. So at A&E, she actually complained that she's having an increase of pelvic pain and she's starting to have more vaginal bleeding with 1 fully soaked pad. So her vital signs at the A&E was actually her temperature was 36.8, blood pressure 110/90, heart rate of 100 beats per minute, respiration rate 20 beats per minute, SpO2 95 and a pain score of 6 out of 10. So at A&E, her HCG level and her FBC were taken by the A&E doctors. So next, she was actually admitted to the gynae ward. In the gynae ward, she actually complained that her pelvic pain has turned from mild to actually moderate to severe abdominal pain accompanied with shoulder pain. And from mild vaginal bleeding, it actually became a moderate vaginal bleeding with 3 fully soaked pads since her admission in A&E. And patient actually turned to be more drowsy, clammy and pale skin. And her vital signs in the ward is actually 37.3 for her temperature, blood pressure 98/50, heart rate 121, respiration rate of 25 beats per minute, and her SpO2 level is decreased to 90% and her pain score has already escalated to 9 out of 10. Okay, so now we will look at the learning objectives. These are our learning objectives for ectopic pregnancy. And next, I will pass on to patient to explain on further.
Hi, my name is Chen Xing, and I am now talking about the pathophysiology of the ectopic pregnancy. So, what is ectopic pregnancy? Ectopic means abnormal place. So, ectopic pregnancy is when the fertilized egg implant at anywhere other than the uterus. Developing zygote will cause the tube to stretch and rupture, leading to internal bleeding, which is a potentially life-threatening condition. There are 3 common causes of ectopic pregnancy. The first is inflammation and scarring of the fallopian tube, which will block the pathway of the fallopian tube and cause the egg to implant in the fallopian tube instead of the uterus. So the second one is hormonal factors. Hormonal factors will also affect the woman to have an ectopic pregnancy. For example, low progesterone will inhibit the thickening of the endometrium wall, so hence the fertilized egg would not be able to implant in the endometrium wall. So the third causes of the pregnancy is genetic abnormalities. There are a few risk factors of ectopic pregnancy. The first one is previous pelvic or abdominal surgery. So for women who had undergone any previous operation on the abdominal, such as cesarean section or appendectomy, will increase the risk of the ectopic pregnancy. The second is previous ectopic pregnancy. So for women who had previous ectopic pregnancy will also increase the risk. The third factor is pelvic inflammatory disease. It is a past infection of fallopian tube caused, for example, by a sexually transmitted disease like Candida trachomatis. The fourth risk factor is for women that age 35 years old and above. The fifth risk factor is for women that have previous operation on the fallopian tubes, such as sterilization. And the following point is for women who had cigarette smoking. Research shows that smokers have an increased level of protein in their fallopian tube, which will cause the higher chances to get ectopic pregnancy. And the last point is the use of assisted reproductive technology such as IVF, as embryos still can travel into the fallopian tube during the IVF treatment, and the implantation of the zygote will occur in the fallopian tube. So as link back to our case scenario, Sarah is actually above age of 35 years old. Okay. The common clinical manifestation is missed period, vaginal bleeding, and sharp abdominal or pelvic pain. Bleeding and cramping in early pregnancy may occur even though in a normal pregnancy. So however, it can also can be a sign of miscarriage or ectopic pregnancy. There are other manifestations such as pain at shoulder, neck, or rectum, which may indicate the fallopian tube had ruptured, and nausea and vomiting with pain, and have hypovolemic shock when there are active internal bleeding.
Okay, I'm Eugene and I will now continue with the diagnostic test of the ectopic pregnancy. Ectopic pregnancy is hard to diagnose as its symptoms can be represent any other pregnancy problems. So the first test is using the serum HCG blood test. So this blood test is to measure the serum HCG level in the blood. So HCG is the human chorionic gonadotropin, which is the placenta hormone. So in a normal pregnancy, this hormone will be doubled in every 48 to 72 hours. So while in the ectopic pregnancies, HCG level rises less than 66% over 48 hours. So means that there is ectopic pregnancy. So we can see in the case scenario that the HCG level is 9,340. So means that it's less than the normal range. So can be suspect that the Madam Sarah has ectopic pregnancy. Okay. Then next slide. Diagnostic test is transvaginal ultrasonography. So for the serum HCG level itself cannot determine the ectopic pregnancies. So it must be incorporated with the transvaginal ultrasonography so that can prove that ectopic pregnancy is happened. So this process involves insertions of the transducer into the vaginas, so to provide detailed images of the organs in the pelvic regions. So from the case scenario, Madam Sarah has done this diagnostic test and the implanted embryo has been seen in the fallopian tube instead in the uterus. Okay, so the third diagnostic test is the laparoscopic examinations. Because transvaginal conditions, the endoscope are inserted through the small incisions made on the abdomen, to visualize the structures in the abdomen and pelvis. So this can view the rupture of the fallopian tube, which is presented in the Madam-Sarah cases. Okay, so the next slide is about the medical management. So if the fallopian tube is not ruptured, the medication therapy, which is methotrexate, can be given. So Madam-Sarah cannot take this therapy as her fallopian tube has been ruptured. So this medication is a folic acid antagonist that can inhibit the cell divisions in the embryo and allow it to be resolved. So it's not applicable as Madam-Sarah has fallopian tube rupture and the serum HCG concentration is more than 5,000. Okay, so the next slide is about the medical management of blood transfusions. So blood transfusion is used to replace the blood lost due to massive hemorrhage. So Madam-Sarah needs these blood transfusions because she developed signs of cold and clammy skin, and also got the vital signs of tachycardia and hypotension, and the lab results have shown that the HB level is lower than normal.
So hi, I'm Natasha and I'm talking about the surgical management. So this is the salpingectomy and it's the removal of the entire damaged fallopian tube, and it's done when there's severe damage or rupture to the fallopian tube. And it's a laparoscopic incision which the patient will be given general anesthesia or local anesthesia, and then a tiny incision is made in the abdomen and a scope is inserted to get a clear view of the pelvic organs, followed by incision and then the removal of the tubes. And it's recommended for Sarah because of her ruptured tubes. So next I'll be talking about the salpingostomy, which is the removal of the products of conception, which leaves the fallopian tube in situ to preserve the fertility on that side. A drug called vasopressin is inserted into the fallopian tube to minimize the amount of bleeding, and then an incision is made to the tube wall into the area of ectopic pregnancy, and the contents are removed using a suction irrigator. So the surgeon will usually try to preserve the tube if the woman still wishes to have children, but this isn't always possible. So next I'll be talking about the pre-op care. So first you need to assess the patient's understanding on the procedure because it's an invasive procedure. So you need to assess the patient's understanding, and then you need to explain and provide emotional support because the removal of the tubes will mean that the patient cannot get pregnant again. And then you need to take consent, take the vital signs for the baseline, maintain MBM status and bowel prep, administer IV fluid to prevent dehydration, and do GXM for any possible blood transfusion, administer pre-op meds, and ensure that the patient gets bed rest before the surgery. So next, I'll be talking about the post-op care. So we need to take vital signs to identify any signs of infection, auscultate any lung or bowel sounds, PCA for pain management, administer antibiotics as ordered, and then the patient's oral intake will be resumed gradually as tolerated, and then insert IDC, and the minimum urine output must be 30 mL, and then you have to assist in ambulation and give compression stockings to prevent DVT. Okay, so now I'll be talking about the possible complications of ectopic pregnancy, which is infertility, damage to the fallopian tubes, maternal death, depression, hypovolemic shock, and future ectopic pregnancy. Thank you.
My name is Jin Chong, and now I'm going to share with you our nursing diagnosis. First, our nursing diagnosis is fluid volume deficit related to blood loss secondary to a ruptured fallopian tube. Second, we will be talking about acute pain related to growing product and of conception against the site of implantation. Lastly, we will be talking about grief related to the loss of pregnancy. Our first nursing diagnosis, which is fluid volume deficit related to blood loss. Our first nursing intervention is to monitor vital signs such as blood pressure and heart rate, as low blood pressure and increased heart rate indicate hemorrhage. Next will be obtain blood sample for group cross match and full blood count to prepare for blood transfusion if needed. Administer IV fluid as ordered to maintain blood fluid volume in the body. Administer blood product as ordered to replenish blood volume lost. And lastly, monitor urine output to assess hydration status. Our second nursing diagnosis, acute pain. Our intervention is monitor patient vital signs including pain score to assess for signs and symptoms of pain. Administer analgesic medication as ordered to relieve pain and promote comfort. Next will be assess patient pain characteristics such as mild pain, sharp pain, or dull pain to evaluate effectiveness of medication. Next, we will keep patient on nail by mouth to prepare patient for emergency operation if needed. Lastly, we will apply warm compress to the affected area to promote comfort and reduce pain. Our third nursing diagnosis is grief related to loss of pregnancy. Okay, so our first nursing intervention is to promote expression of grief by providing privacy, eliminating time restriction, allowing support person allow support person of choice to visit and recognize individualized grieving expression and cultural norm. The rationale is because grief is an individual process and different people react to it differently. Do not negate denial if present. Denial is a coping mechanism that protects the patient from hopelessness. Actively listen to the patient and family expression of grief and avoid offering meaningless words of consolation also help, as being present and actively listen are often the best effective intervention for a grieving patient. Lastly, assess for suicidal potential. Some mothers may not be able to accept the loss and attempt suicide due to the feeling of guilt. Next, we'll take a look at our role play of our health education.
I'm nurse and EG and she is nurse Crystal, and we are here to provide you health teaching before you discharge. So for the wound care, firstly you need to keep your wound clean and dry and change the dressing when necessary, and seek for immediate medical attention when there is any heavily bleeding or severely pain. Then for the activity aspect, you need to avoid sexual intercourse until the bleeding and pain subsides, and it usually takes for 2 weeks. And then please avoid heavy lifting, stair climbing, and working for a long distances to prevent stress on the physician side. So for medication, take the painkiller when you have pain, and also don't forget to finish all the antibiotics they given to you. Okay.
Is there any dietary concern?
So avoid alcohol drinking while you're taking the medicine, and I would encourage you to consume high protein of the diet, so to promote your wound healing.
Thank you very much.
Okay.
To summarize, this is our health teaching, and with this, we have come to the end of our presentation. Thank you.